Hey guys, so today I want to talk about a topic that was fairly confusing to me when it was first presented in class, but I've taken a lot of time to figure it out and to come up with a simple and logical approach to the problem. And this is a topic in nephrology, and it's about glomerular diseases. So this is going to be fairly similar to the lipid video that I made earlier, and just trying to go through the different glomerular diseases in a very systematic approach. And in particularly, we're going to focus on the proteinuria and hematuria scheme because it's not exactly very straightforward to categorize all of these diseases. And so that's what we'll be doing today. If you already know all this stuff, then just ignore this. Really not trying to insult anybody's intelligence, but it's just to help those of you who want to do a review or want a structured approach to proteinuria and hematuria. So the first thing that we're going to talk about, which is totally key to understanding proteinuria and hematuria, is to define the two syndromes, i.e. nephritic syndrome and nephrotic syndrome. So nephritic syndrome is basically a problem where you're leaking blood from the glomerulus into your urine, and so you're going to see your dysmorphic RBCs. And because there's a problem with the glomerulus and you're probably decreasing your perfusion to the kidneys, you're going to end up with hypertension because you're decreasing perfusion to the kidneys, so it ramps up the RAS system. And then because your kidney is now failing, you're going to have decreased urine output, and you're also going to see increasing nitrogenous compounds in the blood, namely azotemia. So these things all fall out from blood being released in the urine. So I really personally don't think there's any need to use mnemonics in this case. Now for the nephrotic syndrome is primarily a disorder of protein leakage through the blood. Okay, so you're going to have nephrotic range proteinuria. So you're going to have more than 3.5 grams of proteinuria per day. Okay, and then because you're losing protein, you're going to be losing albumin, so you're going to be hypoalbuminemia in the blood. Okay, and because you have low albumin in the blood, you're not going to be able to hold on to your volume in the vasculature, and so you're going to have edema. And because your liver knows that you're losing a lot of protein in the urine, it wants to make more protein. And so when it increases its synthetic function, it increases the synthesis of other proteins too, like the lipoproteins, or like the apolipoproteins such as B100 or E. And so you're going to have increasing lipids, and so you're going to have increasing lipiduria as well. So really these four things come from the loss of protein in the urine. These four things come from the loss of blood from the glomerulus. So now we're going to talk about this concept of active urine. So, before we go on to that, the nephrotic and nephritic syndromes are a syndrome, so you can't have one of these and say they have a syndrome. If you have 20 grams of protein a day, but you don't have these three things, you can't say it's nephrotic syndrome because it's not a syndrome. Now, which ones of these do you need to be able to say it's nephrotic syndrome? That is a clinical decision. And all of the stuff that I'm going to talk about later on, and this stuff here, was confirmed by a number of different preceptors, so I am fairly confident that this is accurate information. Okay, so active urine means that you have white blood cell, or red blood cell, or granular, or epithelial, blah blah blah, casts. this is the main issue here. So casts, or you have more than 2 red blood cells or more than 4 red blood cells per high power field on microscopy. But really, I mean, if you see RBCs or WBCs, sorry, that should be white blood cells in your urine, then you know it's active. And when you see casts, or I guess the different cells in the casts, then that's active. So active urine really could be a reflection of RPGN. And RPGN is a glomerular nephritis that is rapidly progressive. And so what this really means is when you have an RPGN, by the Robbins pathology textbook at least, it means when you biopsy it, you're going to see crescents. So when you see crescents, it's very likely that this person has an RPGN. So it's pretty much saying the same thing. An RPGN is where you have a GN that is RP and has crescents. Now, one important question is to understand what exactly is a crescent. So in your glomerulus, you're going to have a crescenteric shaped deposition, which is abnormal. And the abnormality is you're going to have three things predominantly. So one, you have a parietal cell. Sorry, that's terrible handwriting. So one, you're going to have parietal cell proliferation. Two, you're going to have white blood cell infiltration. And three, from all the inflammatory process, you're going to have fibrin deposition. And that's what makes up the crescent. When you see the crescent, it means you have a glomerular nephritis that is rapidly progressing. Your serum creatinine is going up fast. Okay, so this is active, so we're talking about active urine here. And so when we see active urine, it really means, so when you see these things, it means you have an active urine. And so now we need to figure out what is causing the active urine. So, okay, so active urine. Now there's three things that cause active urine. One is you have an antibody to your glomerular basement membrane. Two, you have a deposition of immune complexes. Three, you have an ANCA pathology. Okay? So, now let's go through each of these. For your glomerular basement membrane antibodies, if the person is bleeding from their lungs, which you'll see with hemoptysis, then you can say that it could very well be good pastures or GPA. If they are not bleeding from their lungs, then it means that they just have an other type of GBM antibody disease. Okay? And by the way, this means the lung and that means bleeding. So those are two lungs and those are the trachea. Alright, so that's GBM. Okay? So now there's the immune complex deposition. So the way we look at immune complex deposition is by looking to see whether or not the complement has been deposited in the glomerulus. And so the way to look at that is to look at the serum complement levels. Okay? So if the serum complement levels are normal, then it means that the serum is not being deposited in the glomerulus. And so things that do this are IgA, and a type of IgA called heme line purpura. Now, if you see that the serum complement is low, it means that it has been probably deposited in the glomerulus. And things that do this are lupus, infectious endocarditis, and your post-infectious glomerular nephropathy. As well, you can have cryoglobulinemia, as well as your membranoproliferative glomerular nephropathy. So that was under reduced complement levels in the serum, which is a type of immune complex deposition when you see active urine, which is when you see these types of casts. So now we're going to move on to the ANCA diseases. So with ANCA, you're going to look to see if they are C ANCA positive or P ANCA positive. If they're C ANCA positive, there's only one thing that we need to know that will do this, and that is your granulomatosis with polyangiitis, aka Wegener's. The P positive ANCAs are those that we don't really need to know too much about, and that's one, Churg-Strauss, microscopic polyangiitis, and idiopathic crescenteric glomerulonephritis. So that is the scheme for active urine, and there's a very good reason why we went through this. And so now let's go through proteinuria, just trying to make this board stay up. Okay, so I think that'll work. Alright, so for proteinuria, so now this is separate. We're going to look at proteinuria now. So the way to look at proteinuria is to first rule out the things that can cause, I suppose, like a false positive glomerular proteinuria. So the first thing, you're going to rule out some sort of benign causes, and then the second thing is you're going to see if the protein is coming from the tubules. Okay, and then the third thing is you're going to see if it's actually coming from the glomerulus, which is the biggest problem. Okay, so when you see more than 50 milligrams of protein on repeat testing and on overnight testing, you're going to try to rule out these things. So you're going to rule out, okay, so was the person febrile? Was the person doing exercise? Did the person have a UTI? And is this person like a really tall kid? Okay, so could have benign proteinuria. So once you ruled that out, then you're going to look at the tubules. So to look at the tubules, you're going to see if there's an abnormal protein deposition. So you're going to do your serum protein electrophoresis, and then if you see monoclonal antibodies, it's positive, then it means a number of things. One, it could mean you have multiple myeloma. So this is kind of an overflow proteinuria. So you're just making way too much protein and it's coming out in your urine. Multiple myeloma, or you have your gamopathies such as MGUS. Now, if your SPEP is negative, then it means you could have problems related to drugs, Fanconi syndrome, or RTAs. So that's your tubules. So you see protein in the urine, rule out these benign things, and then look at your tubules. So is it too much protein being made? Look at the history of drugs. Look at the long-standing history to see if there's Fanconi's, and then look at the urine and the acid, urine pH to look at RTAs. Now let's look at the glomerular stuff. So the glomerular proteinuria is either active or it's non-active. So there are 5 causes of non-active glomerular proteinuria. and they are MCD, FSGS, membranous nephropathy, and the secondary causes like diabetic nephropathy and amyloidosis. Okay, so now we have proteinuria. Proteinuria, first thing, rule out the benign causes, look at the tubules, do an SPEP, and then you're going to look at the glomerulus. And so if you see the way you know that it's coming from the glomerulus is if you see that your red blood cells are dysmorphic. Okay? So then by history and your urinalysis, you're gonna see that if it's non-active glomerular proteinuria, it's one of the 5. And then if it's active proteinuria, then you're gonna go back to your active urine scheme, and it could be any of these things here. So anything that is active glomerular proteinuria could be anything in the active urine scheme. So that was proteinuria. So now we'll just move on to hematuria. The board is completely full, so I'll just rub out the nephritic and nephrotic syndrome because I think everyone pretty much understands that. Okay, so now let's look at hematuria. Okay, so again, the approach is the same. So we're going to rule out the false positives, okay? And the false positives could be things like myoglobinuria, or you have red supernatant. So I'm not even going to write that down because that's just so obvious. We rule out the false positives. Okay, then we're going to look to see if the stuff is coming from the glomerulus or not coming from the glomerulus, in which it's coming from the other parts of the urinary tract. Okay, so remember that isolated extraglomerular hematuria is cancer or bladder cancer until proven otherwise, and that's when you ask about smoking, etc., etc. So you're going to think about things like cysts, you're going to think about the interstitium, you're going to think about vascular causes, you're going to think about stones, you're going to think about BPH, and you're going to think about cancer. Okay, so that was the non-glomerular causes of hematuria, and now let's move on to blood that's coming out from the glomerulus. Sorry, this was a terrible mistake. You don't see blood coming out when you have proteinuria, so that was a mistake. You're supposed to see protein when you have proteinuria, and you're going to know that the blood is coming from the glomerulus when you see the dysmorphic red blood cells on microscopy. So I do apologize for that mistake. So when you think about the glomerulus, again, you're going to think about, is this active or is it not active? So for non-active, there's really only 3 things that you should know about. And one is you could have a thin glomerular basement membrane disease. 2, you could have Alports. Remember, this is the one with the defects to the ears and the eyes as well. Okay, and then you're also going to have your IgA. So those are the 3 things that cause a non-active hematuria from the glomerulus. Now what about active? This is just like proteinuria, where we're going to resort to the active urine scheme right here. So whenever there's active urine, whether it's hematuria, whether it's proteinuria, any of these things can cause an active urine. Okay? So what we talked about today was nephritic syndrome, nephrotic syndrome. We defined what active urine was. We talked about what RPGN was, as well as what crescents were, and that they pretty much mean the same thing. Falls under active urine. when you have active urine, you need to figure out what is causing it. And so it can be coming from antibodies to the basement membrane, it could be deposition of immune complexes, or it could be an ANCA vasculitis. And the way to do that, look at whether or not there's pulmonary hemorrhage. Look at the serum complement levels, and then assess for C-ANCA and P-ANCA positivity. That way, you figure out what your active urine pathophysiology is. Once you know the active urine scheme, you can move on to the proteinuria scheme, where you're going to rule out certain things. You're going to look at your tubules, then you're going to see, is the protein coming from the glomerulus? And usually you know it's coming from the glomerulus when your dipstick tells you that there's albumin, but of course that's not always foolproof, so you want to make sure that it's coming from the glomerulus. So urine that's coming from, so proteinuria from the glomerulus can be active, can be not active. 5 causes of non-active glomerular proteinuria, and if it's not that, then it's active. And if it's active, then you look back here to see which of the causes is the culprit here. So proteinuria, done. Hematuria, same thing. Rule out the false positives, like you have a lot of myoglobin in your sample, or think about your upper urinary tract and your lower urinary tract. Has there been an infection, interstitial causes, the blood, BPH, and cancer? Ask about smoking. Same thing. Then you're going to look at, is the blood coming from the glomerulus? Is it active or is it non-active? If it's non-active, 3 causes. If it's active, look back at the active urine scheme. So I think that's pretty much it. Oh, and then, so once you have these 3 causes, then you simply have to remember the clinical manifestations and the pathological manifestations of these things and these things, and then you'll be able to tell the difference between each of these. But then you can always tell the difference between this and this, whether it's not active or active, by looking at these criteria. So I'm not going to go over what differentiates thin from Alports from IgA and McDonald's from FSGS or whatever, because then this video is going to be way too long. However, one more thing. Okay, I'm not sure I really remember what I was going to say. It was kind of important, but oh yes, one more caveat to keep in mind is lupus and IgA. Although I put it here and although I put lupus here, okay, so these 2 things can cause any of these. It can cause any of these, it can cause any of these, it can cause any of these. So IgA and lupus can fall into any category. But other than that, this and this and this would be a fairly systematic and a reasonable approach to looking at proteinuria, hematuria in the context of active urine. So hope that helped, and good luck on the exam on Friday.